Welcome all today's class. So this class is on management of breech presentation. It is a green top guideline number 20b published in March 2017. Okay. So what does the guidelines say regarding the counseling and information to the womb? The guideline says that offer ECV at term unless contraindicated. So if you have got a term breech, the first management as per the guideline is external cephalic version unless contraindicated. Okay. So if ECV is declined or it is unsuccessful, in that particular case, counsel on planned vaginal or planned cesarean section. So first option ECV, then counsel them either planned vaginal or planned cesarean section. Okay, so planned cesarean section, the advantage is that perinatal mortality is slightly less, but compared with the vaginal birth. Okay, then risk and difference, how this planned cesarean section is help. It will avoid the stillbirth after 39 weeks of gestation. It will avoid the intrapartum complication, and it will reduce the risk which is specific to the vaginal delivery. So there only you have got a role of planned cesarean section. Okay, but the considering the perinatal mortality, here there can be SBA. They can ask you, because now we have got a term breech, we have the option of ECV converting it to Kifan and the deliver vaginally, or we have an option of to go ahead with the vaginal breech delivery, or we have an option of elective cesarean sections. So these are the three options which are available to us. Now they are talking about the perinatal mortality risk with respect to each. Okay, so if you plan cesarean section after 39 weeks of gestation, the list perinatal mortality 0.5 per 1000. If you go ahead with a planned vaginal birth, then it is around 2 per 1000. That is 4 times increase in the risk of perinatal mortality. Okay, so here it was 0.5, it is 2. And if it is a planned cephalic, so if you convert to Kifal, if you do ECV and it is a planned cephalic, then it is 1 per 1000. Okay, so vaginal breech birth increases risk of low Apgar, short-term neonatal complications, but there is no increase in the long-term morbidity. So vaginal birth only there is a transient, or the immediate risk is low Apgar and short-term neonatal, but long-term there is no morbidity. That is why vaginal birth, breech birth can be considered. Okay, counseling should be balanced, unbiased, and discussed. So these particular figures, please remember from SBA point of view. Okay, now maternal risk. For planned cesarean section, there is an increase in the immediate maternal complication as compared to the vaginal birth. Now, what is the risk hierarchy? If lowest is seen with the successful vaginal breech birth, okay, highest will be planned cesarean section as far as maternal risk are concerned, and highest will be emergency cesarean section. Okay, so if the cesarean section is carried out in emergency, then it is a high risk. Okay, 40% of attempted vaginal breech birth will land up with, so success percent 60% will have successful vaginal birth, but 40% of planned vaginal may undergo cesarean section. So this they can ask you in the SBA. Okay, how many patients require emergency cesarean section, or what figure you need to quote to the patient. The patient is asking that regarding the chance of emergency cesarean section. Okay, she has opted for vaginal birth, but still there is a chance of emergency cesarean section. That chance is 40%. You need to remember. Okay, long-term risk of cesarean section, it will increase the risk of complications in future pregnancies, such as she may have to undergo either VBAC, or there are chances of cesarean section or placenta accreta spectrum. Just now we have seen, because this time she is going to undergo elective cesarean section, and elective cesarean section has got a high chance of either low-lying placenta or placenta accreta spectrum. Okay, so provide individualized risk counseling based on women's respective reproductive plans. Okay, future baby risk, cesarean section associated with slightly increased risk of stillbirth in subsequent pregnancies. Okay, so there is a little increased risk of stillbirth in subsequent pregnancy. So what are the factors affecting safety of vaginal breech delivery? Okay, so these factors, you need to screen these patients on ultrasound and look for 3 things on ultrasound. One is a neck, second is a leg, and third is a expected fetal weight. So 3 ultrasound features are going to be very, very important. That is hyperextended neck, expected fetal weight more than 3.8 or less than 10th percentile, or if it is a foot link presentation. Okay, And other parameter is a fetal compromise. If you have got any feature, maybe her Doppler is abnormal or something like that, in that particular case, we'll say that the fetus is compromised. So these patients are not suitable for vaginal breech delivery, and you have to go for cesarean section directly. So when you have been given the scenario, you concentrate on these particular features which are given in the investigation. Okay, so the best option in these patients will be cesarean section. Okay, what is important for the vaginal breech delivery? It is a skilled attendant. The most important thing for the vaginal breech birth is a skilled attendant at birth. Okay, women should be referred to the units with the experienced staff. Intrapartum, for unplanned breech birth, what does the guideline say? It will depend upon the stage of the labor, risk factors, available expertise, and informed consent, no doubt. But if the patient presents in the second stage, advanced second stage, we should not routinely offer cesarean section. Okay, there were many questions on the this breech one in one of the exam. Okay, so it will always depend upon what kind of scenario you have got. Like you may have a scenario of an antenatal patient, term patient with ultrasound suggestive of this, then your option will be planned cesarean section. Okay, the planning will be around 39 weeks of gestation. Okay, they might confuse you with respect to the gestation also, 37 weeks, 38 weeks, 39 weeks, etc., etc. Your option may be correct, but the full option should be correct. Okay, then intrapartum, we have seen if she presents in the advanced second stage, then we should not offer her routinely cesarean section. If ultrasound is possible, suppose if she is in latent phase, the our option will be, we will check for three things on the ultrasound, that is neck, legs, and expected fetal weight. Rule out these things, and then we may offer her vaginal breech delivery also. And all maternal units must provide protocols and skill supervision for unplanned breech labor. Okay, now what is the role of induction augmentation in term breech labor management? Induction not recommended. Augmentation only if there is a epidural and low contraction frequency, then only you augment with oxytocin. Okay, so no induction, augmentation selectively if the contraction frequency is less, or and epidural should be in place. Epidural effect is unclear, it may increase intervention risk. Fetal monitoring, always continuous fetal monitoring is indicated here. Okay, then place of birth has to be hospital with immediate cesarean section facilities, and not necessarily you need not do the vaginal breech in the theater. They are not expecting you to have vaginal breech. The breech can be delivered in the labor room itself. Okay, only thing is that you need to have immediate cesarean section facilities available. Okay, guideline protocol adherence and reduces neonatal morbidity. First stage and second stage, so adequate descent is required before active second stage. Okay, so there has to be adequate descent in the first stage, okay, before the active second stage begins. Maternal position, there are two positions. One is a semi-recumbent position, second is all four positions. Okay, but it will depend upon the patient's preference and the staff experience also. Okay, now what are the principles of active second stage management? When intervention should be done? So assistance is provided only if there is a delay or there is a fetal compromise, otherwise no unnecessary traction. Okay, obstetrician or midwife must be skilled in breech delivery manuals, and the choice depends on the operator's experience. Okay, so what does the guideline says? What is the scope of the guideline? From here up till now we have just seen the summary. Now we'll go into the details of the guideline. Okay, guideline covers regarding the mode of delivery for breech presentation. It focuses on the decision on delivery route and techniques, excludes antenatal or postnatal care, and ECV is we are going to discuss separately. Okay, now what is the background epidemiology? What is the incidence of breech overall? It is around 3 to 4% of the deliveries breech is seen. Okay, it is more common in preterm, associated with uterine and congenital anomalies. There is a there is a recurrence risk and nulliparity. So these three things: one, association with the congenital anomalies, it can be a recurrent breech, or it is also seen in nulliparity. Most of the cases are preterm. Overall prevalence is around 3 to 4% of total deliveries. Term breech outcomes versus cephalic outcome. Okay, now little bit of term breech trial. This led to decline in vaginal breech birth, and cesarean section rate was increased. Okay, in term breech trial, vaginal breech still occurs because of maternal choice, undetected breech, failed ECV, etc., etc. So there are certain studies, but will not, because they are not asked, so we'll skip this. Even the term breech trial, only things you can remember, planned cesarean section in this trial has reduced cesarean, reduced perinatal mortality from 1.3 to 0.3%, and also decrease serious neonatal morbidity. Okay, no long-term neurodevelopmental difference at 2 years. Okay, but this was criticized mainly for poor case selection. Okay, this term breech trial was criticized for poor case selection, lack of monitoring, and absence of senior staff. This was one of the lacunae for this TBT. Okay. There is another study called as Premoda. It was mainly strict protocol. Then planned vaginal breech mortality they found very low. Okay, almost equal to cesarean section. And vaginal breech increases the risk of low Apgar and birth injuries, but no increase in the serious neonatal morbidity. So as per this trial, no doubt there is a slight increase in the low Apgar, but there is no serious neonatal morbidity. Okay. So future maternal health, subsequent pregnancies, cesarean section increases the long-term risk compared with to vaginal birth. Risk will include uterine scarring, then high chances of requiring repeat cesarean section, increased risk of blood transfusion, endometritis, hysterectomy, maternal death, etc. And the risk of subsequent scar rupture if the VBAC is given in subsequent pregnancy is 0.5%. So you should remember this particular figure of 0.5%. In routinely what they quote for rupture of the scar during VBAC is a 0.5%. Okay. Then placenta related risk can be there. Placenta previa, placenta accreta spectrum strongly linked to the prior cesarean section. Risk rises with the number of cesarean section that we have just seen in the last presentation. Abnormal invasion placentation will increase 0.3% with one cesarean section to 2.33% with four cesarean section. Higher risk after elective cesarean section than after emergency cesarean section. Complication will be massive hemorrhage, hysterectomy, urinary tract injury, maternal death, etc. etc. Then risk to the babies, cesarean section is linked to the small increase in the risk of stillbirth in the subsequent pregnancies. If the woman undergo elective cesarean section in this pregnancy, there is an increased risk of stillbirth in the subsequent pregnancy. Okay. Then what are the risks in the VBAC? There can be risk of uterine rupture. We have just seen the figure. What is the figure which they are quoting? Scar rupture 0.5 per
0.5%.
yeah, 0.5%. Okay. Then perinatal mortality after one cesarean section, it is up to 12.9 per 10,000 birth, mostly due to rupture. Okay. Antenatal assessment for vaginal breech birth. So what antenatal assessment we should do? Assess for risk factors. If present, directly go for a planned cesarean section. Higher risk of vaginal birth, breech birth when high risk, in which cases the vaginal breech will be having high risk if you find three factors on the ultrasound and the fetal compromise. Which are those three factors? One is a hyperextended neck, second is a fetal weight more than 3.8 or less than 10th percentile, next is a leg, that is foot-link presentation or antenatal fetal evidence of fetal compromise. Okay, so these factors we need to rule out. Okay, so these were the same things. Okay, we have seen. Then skill and experience of birth attendant in vaginal breech birth. Okay, the most important thing is the skill and experience of birth attendant. Essential requirement is the presence of skilled birth attendant. Units lacking in the experienced person, there is a higher risk, so these patients are to be referred to the specialist centers. Okay, skilled person availability strongly influences the perinatal outcome. So strong association, good perinatal outcome will be seen if you have got a skilled person. Okay, so these are the few important points. So general principles of the management: one, it will depend upon the stage of the labor, presence of risk factors, availability of the skilled person, and informed maternal consent. So for vaginal birth, these are the 3-4 things which are important. Then labor management. Active second stage, do not routinely offer second stage if the patient is directly presenting in the labor in the second stage and she is breech. Routinely cesarean section is not offered. If time allows, we'll carry out ultrasound. We'll see three things. Which are those three things? Neck, leg, and expected fetal weight. Three things we'll see and counsel them for planned vaginal breech. Okay, many cases will present late. This is one of the question which they ask you, that how many percentages of breech are missed and they present in labor. So 25% cases are undiagnosed until labor. So normally we diagnose this breech accurately, but 25% cases are still missed, okay, and they will present directly in the labor, okay. Now we discuss about safety and risk. All maternal units must provide skilled supervision and protocols for unplanned breech. So these patients should have some protocol. So unplanned vaginal breech, higher risk than the planned, but late cesarean section will also have got a definitely risk. If breech is very low, cesarean section attempt may increase maternal and perinatal risk. Okay, vaginal delivery attempts in the theater under spinal or cesarean section with breech on perineum also increases the risk. Overall, there is increase in the definite risk even in cesarean section also. So unplanned cesarean section incidence is around 25%. Okay, that you can remember here. Intrapartum management of term breech evidence is limited. Guidance is based on physiology, expert opinion, low complication case series. There are two main approaches. One is the interventionist approach that is suggested by Premoda study. Second is a less medicalized traditional UK approach. This is what they less intervention here. So one which promotes intervention, second is a less intervention. Both will require close supervision, readiness for cesarean section, and intervention if needed. What is the role of induction? We have seen no role of induction. Augmentation only when the contractions are less, okay, and the epidural should be in place. These are the two things which are very important, okay. So augmentation is not done as a routine or prophylaxis, may be considered if contraction are low with epidural anesthesia. If there is adequate progress, best indicator for fetopelvic proportion. If there is a good progress, that means the fetal-pelvic proportion is better, good, okay. So fetal monitoring in breech labor. What kind of monitoring is required? It is a continuous electronic fetal, no role of intermittent auscultation. It is a continuous electronic fetal heart monitoring, okay. It is recommended because it may improve neonatal outcome. Rationale is that breech, there is an increased incidence of the cord prolapse and the compression, okay. Non-hypoxic fetus will tolerate labor and delivery better. If patient declines electronic fetal heart rate monitoring, then you go for intermittent auscultation. Switch to electronic fetal heart if there are abnormalities. Okay, abnormal electronic fetal heart monitoring before active second stage, recommend cesarean section unless you see the buttocks are visible or there is a rapid progress. So if you have a abnormal before second stage, then your choice of management will be recommend cesarean section. Okay? Fetal blood sampling is not recommended. Place of vaginal birth should occur in the hospital with immediate cesarean section facilities. And when you are giving vaginal birth trial, it need not be routinely in the theater. But because if you transfer these patients to theater, that increases the maternal stress. So they say that delivery should be in the labor ward only. Birth in water is not recommended here. Okay. Then guidelines for breech management. The key requirements are careful case selection and the skilled attendants available. So careful case selection, we will have these ultrasound criteria, what we have discussed. There should be no fetal compromise, and skilled birth attendance is the most important. Management per established protocol, better outcome when strict selection guidelines are applied. Okay. Then first stage and second stage in the breech. Manage first stage as a cephalic. So there is no difference in the first stage. Amniotomy only for clear indication. It will reduce the cord compression risk. If there is a slow progress, consider cesarean section. Okay. Sometimes these questions are combined with the labor management. So these cases, they will combine with the findings of the labor. At this time, these were the PV findings, and after 4 hours, the reassessment was done, and these were the PV findings. And if you find that there is a slow progress, then your management will be considered cesarean section. Okay. So generally these guidelines, they may combine with the NICE guideline also. So we have to cover NICE labor guideline and the fetal heart rate monitoring. These are the only two things which are remaining now. With epidural and less than 4 contraction, you can use oxytocin. This we have just seen. Okay. Passive second stage, allow breech to descend before active pushing. If breech is not visible within 2 hours of passive stage, then again go for cesarean section. Okay. So passive second stage, you will allow the breech to descend before active pushing. If the breech is not visible within 2 hours of passive stage, then you recommend the cesarean section. Maternal position, there are two positions they have mentioned. One is all four, and second is a semi-recumbent. Okay, one is a semi-recumbent position, second one is a all fours position. What is the advantage with all four position? It increases the pelvic dimension, then lower perineal injury and shorter second stage, favored by many experienced operators. But what is the limitation? Maneuvers are harder. Most obstetricians more familiar with these maneuvers, they feel comfortable with the dorsal or semi-recumbent position. So you may have to change the this all fours position to the semi-recumbent position if the intervention is required. Okay. If your operator is skilled, the maneuvers can be done safely in all fours also. Now, active second stage and breech delivery. Encourage pushing only once the breech is visible. Hands-off approach. Intervene only if there is no progress after buttocks or umbilicus delivery. If there is a poor fetal tone, color, or distress, or arms are extended or neck is extended. In that particular case, we may have to intervene. Okay. Avoid traction and unnecessary stimulation. It prevents fetal trauma. Then grasp only fetal girdle, no other soft tissue to be grasped. You have to grasp to the fetus by girdle. Okay, avoid hyperextending the neck. Episiotomy is not routine, it is only selective episiotomy, and you follow this particular timing for intervention. From buttocks to head, you can wait up to 5 minutes, and from umbilicus to head, delivery should be within 3 minutes. Okay, so these are the time limits which they have mentioned in the guideline. 5 minutes from the buttocks to the head and 3 minutes from the umbilicus to the head. Okay, the attendants must be skilled in breech maneuvers. Choice will depend on their training and experience. Okay, now coming to the management of preterm breech. Routine cesarean section is not recommended for spontaneous preterm breech. So your patient is a preterm, she is coming spontaneously in labor, do not offer routine cesarean section. Decision should be individualized. It will depend on the labor stage, breech type, fetal status, and operator skill. Okay, at threshold of viability, that is between 22 to 25.6 weeks, cesarean is not routinely recommended. Okay, borderline gestation, cesarean section is not recommended. Okay, planned cesarean advice if preterm breech delivery is required due to maternal or fetal compromise. 25% of preterm births are iatrogenic. Okay, so how many percentage we carry out for some indication like preeclampsia, FGR, abruption? We need to deliver these patients irrespective of gestation. These are account for 25% of preterm births. Okay, and may require elective cesarean section if they choose. Okay, so what is the consensus? Evidence is insufficient to mandate cesarean for all preterm breech. Many obstetricians still prefer cesarean, but acknowledge selection bias in studies. Decision should be by experienced obstetrician with woman and partner, considering the stage of the labor, and beware unnecessary emergency cesarean section when fetus already delivered vaginally. Okay, so this can also sometimes happen. Okay. So management of singleton preterm breech, if she is in labor, manage as a term breech only. Avoid routine amniotomy. Then head entrapment, sometimes they can ask you this. If there is a head entrapment, what will you do? If what you will give lateral cervical incision at 2, 6, and 10 o'clock position. Okay, at 2 o'clock, 6 o'clock, and 10 o'clock. Okay, so give lateral cervical incision at 2 o'clock, 6 o'clock, and 10 o'clock. If you are doing cesarean section, it can extend uterine incision, J-shape or inverted incision for the head entrapment you may have to take. Okay, you will extend the cesarean section and make it J-shaped or inverted P. Sometimes tocolysis you can consider for head entrapment, but generally the question is on this. Okay, sometimes they can ask this. Okay, similar entrapment rates in vaginal and cesarean delivery. So the head entrapment rates are same. Okay, now you are having second twin in the breech. Okay, again routine cesarean section is not recommended. 40% of the cesarean second twins are non-vertex at delivery. Okay, presentation of the second twin is unpredictable. Cephalic delivery may be encouraged by guiding the head or expedited by the internal version or breech extraction. No clear evidence for safest approach. So if you have a second twin, in almost 40% of cases, it will be a non-vertex. So you will guide this head to be a presenting part. Okay, or you can expedite by internal version or breech extraction. Okay, so organizational and governance for vaginal breech delivery. Again, all these things are not important from second part 2, so I'll skip. So that finishes today's topic also. Thank you.